even in the new era, called the Trump era, right?
Thank you. There we are. We have the slides on. Right, thank you. Thank you. Look, this is more of a story than anything else, but just to give you a background, I am from Australia, and we have the Royal Australian New Zealand College of Ophthalmologists, which is an institution that's involved with training, institution that's involved with standards and so on. So it's not an association, it's actually a training institution. But the problems in that part of the world, especially where I work, is usually slightly different from the rest of Asia, where for us macular degeneration, glaucoma, and diabetes are our major issues. That shows you the distribution of ophthalmologists in the region. They're all concentrated around the best parts of the place to live in, which is the coast. But, it's all very nice, but we do have problems in Australia. And we have an indigenous population which has got a very high prevalence of blindness and vision impairment, which is much more than the rest of the population. And every year we get a report from the government saying what they're doing. And every year it shows that it's not possible to close the gap between the indigenous population and the rest of Australia. And so, we are bombarded by reports all the time, and really not much work is happening. So I think this gap that we are talking of between the indigenous and non-indigenous population is one of our biggest problems. Of course, the disease patterns are changing, and just after COVID, I went to meet the health minister, and I said, look, I'm not very happy about the direction the government is taking, and whether you would have the funds and whether you would have the direction post-COVID to be able to handle all this. And so he said, look, why don't you work with the government and tell us what to do? So that was the first point of contact between the profession and the government, and we coined this Vision 2030 and beyond, because I think it's a fundamental mistake to say we'll finish everything by 2030. That never happens. So this was launched in 2022, and really it's got 6 pillars: workforce training, service delivery, closing the gap, preventive health, sustainability, and global eye health. And I'm going to just touch on one or two of these. Why are we paused? So this whole thing started in, that ophthalmologists doing things many years ago with Fred Hollows. And one of the projects that's going on in Western New South Wales, where Sydney is the capital, it's only for 125,000 people, but they are spread out in an area that's the size of France. So their services are delivered by aircraft, by road, and so on. In the northwest of the country, where all the mining is, the distances are even more, and there's a different model being used there, where vans such as this travel and actually see patients, treat them on site, and then they use aircraft also and use telehealth. So that shows that there's been increased accessibility for Aboriginal patients once all these measures have been put in. So here are some pictures, and this is a complete, ophthalmologists, optometrists, nurses, health workers, and all together. And of course, they've been doing a lot of research in terms of getting the database on all machines for Aboriginal patients too. I think they've been working with Google. The relationship between India and Australia also is evident in many remote parts of Australia, where we've got doctors who can work under slightly more difficult conditions, are manning ophthalmology services, such as in the center of Australia in Alice Springs Hospital. So we have a similar program in 2024, and we have brought the whole eye care sector together. Now remember that in Australia, 85% of eye health service is delivered by private practitioners, which is quite unique. And so it's also a big challenge trying to put everybody together. So we have to work with optometry, we have to work with orthoptics, we have to work with the general physicians and so on. And so we've been running workshops to come up with consensus areas, not where we disagree, but where we agree. So when we present to government, we tell government, look, this is the direction we move forward. The government wants to listen to one voice. They don't want 5 people coming and telling them 5 different things. So we've had a very positive outcome from these workshops, and the government now calls the ophthalmologists and say, okay, what do we do in this space? So that is the win that we've had for the profession and therefore for the patients. We, of course, are involved with media advocacy and sending messages to the public about where things are going on. Some examples of positive steps have been increase in number of training positions, and also we are demanding from the government that they have KPIs. When they give money, they should say, well, there are KPIs, otherwise you don't get any more money after this. We want to create an atlas of healthcare delivery standards so there's uniformity in the country and so on and so on. So look, it's a big process, but this is the important part of ophthalmologists engaging with government, dealing with politicians, utilizing things like the elections as key points to push the agenda for eye care forward. So we collaborate with a lot of organizations in the country, and we have a similar program in New Zealand. Remember, we are Royal Australia and New Zealand College, and they have a different system, but their problems are basically quite the same. Coming on to the 6th pillar of this, which is our global health platform, we concentrate on the Western Pacific Rim as well as the South Pacific. When you tell somebody about the South Pacific, you think of a thatched hut and people dancing and you're having a nice sit on the beach, but actually the problem with the Pacific is not so Pacific, right? Economically, the Pacific hasn't recovered from COVID. And in the Pacific, we've got a small population of over 12.5 million people spread out over a very large area. If you leave Australia and New Zealand out of it, it's 12.5 million people. But what's common in all these people is there's a very high rate of visual impairment and blindness, and really diabetes is coming in, the demographics are changing in, and I think the future doesn't look very bright. It doesn't matter which country you look at. There's very limited capacity within the Pacific Island countries. For example, they said this country of 120,000 or 220,000 has got one ophthalmologist. One ophthalmologist can do nothing. So we need to really see what we're going to do. My own journey in the Pacific started in 1994 in Papua New Guinea, and you can see us operating on boats, but the second part of the journey started in Timor-Leste 25 years ago when they got independence, and over this time we've been able to set up their whole system and handed it over to the government in 2023. So over a 15-year period, the RAB showed that the prevalence of visual impairment and blindness reduced from 7.7% to 2.8%. And I think that things are still improving. So why was this program successful? That's because we utilized some very unusual, not standard things. For example, we sent people for training to India and New Zealand, India and Nepal from there. We didn't call them to Australia because I believe that they have better training here than the standard thing of bringing them to Australia. They can do much more, and of course they create good links. We had education and educationists coming from all parts of the world, a truly global classroom. We sent them for very short-term fellowships, go and learn specific things rather than spend 2 years doing all that, and worked on the complete eye care workforce. So, but I think the greatest achievement was that we engaged with politicians right from the beginning, and they really made sure that any small hurdles were going over, so were fixed. And I think that's the important thing when you embark on programs like this, that you engage with the government and the politicians. So now the rest of the Pacific has come to us and said, we also want programs like that. So we have now focused on the rest of the Pacific, which are 14 other countries. But all this has been possible not because of the strength of RANSCO alone, but also our links with organizations in India and Nepal. We have MOUs with All India Institute, we have MOUs with AIOS, And we also wrote to the Indian Prime Minister and the Australian Prime Minister saying we are working together in this space to tackle the issues of blindness, especially due to diabetes. The All India Ophthalmic Society has last year started work in Samoa. Here are some pictures from there, and also in Tonga. You recognize Samar Basak, he's your president, who's just finished. And we also have a WhatsApp group that works as a telemedicine base for the whole of the Pacific. So anybody in the Pacific sends in a de-identified problem, the response is generally available within 24 hours. We invite them, the Pacific Islanders, to our annual meetings. And we're also working with Dr. Sahu's organization, International Society for Manual Small Incision Cataract Surgery, by improving cataract surgical outcomes in the Pacific. We've held workshops in Fiji. This is a recent workshop which is very well regarded, and they want some more. We're also looking at the effects of climate change, which are very, very close to the heart of the Pacific Islanders, and looking at carbon footprinting, not only for cataract surgery, but also for intravitreal injections. So we're learning a lot from India. We're learning a lot from what's going on here into what would be best practice, not only for the Pacific, but also for the rest of the Asia Pacific. And the college has put out sustainable practice guidelines for not only cataract surgery, but also for injections. We have a program where we get refurbished equipment, get it certified by the company, and actually send it across to hospitals within the Pacific. And this is looked after by companies such as Zeiss and Alcon and so on, so that the equipment get a second lease of life. Here's a colleague of mine who's got a 56-foot boat, and he goes from island to island transporting equipment and just creating that little link between these things. So lastly, this effort was able to speak to the health ministers of the Pacific, bring eye care on the agenda. They formed a resolution which was adopted by the Commonwealth Heads of Government meeting in October last year in Samoa. Here are some photographs of that. So really we've been able to bring eye care above the horizon so that I think it's got a good future. All this is important, as you said, in Trump's era, because there is so much uncertainty in the world. COVID was one. The current situation is the second, and I think it's no longer business as usual. We just need to make sure that as ophthalmologists, we continue to be clinicians, scholars, researchers, but also advocates for the patient, which requires connection with governments and understanding of what's going on in the world. So I'd like to end by saying that on the 1st, we had an AIOS RANSCO function. The New Zealand High Commissioner was the chief guest, and he had one message, and he said, when societies get together, when doctors get together, it makes it much easier for governments to do their business because they've got the professionals in front. Thank you.
Thank you, Nitin. I think the most important part you touched at the end was the sustainability part, which is very important, at least for us to do this kind of a good work, especially in outreach and underserved. Unless we sustain in our regular work, that will be very difficult to do. And I was just seeing a news that the people who are kind of governing the sterility now are all squashed. Their jobs went off yesterday. It's a big news there. The team which found that the tear substitutes were contaminated, that team is gone. So people are worried about a lot of things, but it's so important in keeping in touch with politicians is also quite important. I mean, you touched upon all that. Thank you again for giving the keynote address.